everybody, Dr. Reynolds.
I'm Dr. Calltrider here.
So we made what we thought was a really good steroid video. About the risks and benefits of steroids in the urgent care over different complaints. We finished it. We said, "Wow, high five!
High five,
I
man!
thought that went really well." In 16 minutes, that's horrific.
That's so long. Nobody's gonna sit.
So we wanted to make an abridged version of that. We're going to shoot through some bullet points really fast that don't have any explanation and sound like we don't know what we're talking about, or at least not presenting evidence to you. If you'd like to go watch the longer video, I think it has more information and the evidence that we found doing a literature review. So here's kind of some of the big bullet points, okay? Systemic steroids in current literature have pretty much no benefit in acute sinusitis.
True.
Flonase, intranasal steroids, does in both viral and bacterial sinusitis. So feel comfortable using that. For a sore throat, as long as you don't think it's strep throat, a select group of populations, they call it, will benefit from getting some steroids for a sore throat. URIs in little kids, unless it's true croup, unless you're treating them like croup, plus minus admission to the hospital, grade A evidence to stay away from giving kids steroids in URI. Back pain, if it's a chronic back pain, if you're worried about true nerve impingement, if you're worried about actual inflammation in the lower back, steroids are indicated. Acute back injuries, not a lot of evidence to suggest that anybody's getting help out of systemic steroids for that.
Right.
And we touched a little bit on Toradol.
Yeah, we did.
You need to be checking creatinines on people you're giving Toradol to. If you send someone into acute renal failure because they had a little mild CKD or an AKI and you give them Toradol and they go into acute renal failure, I've had multiple people on medical review panels, MDs who go to court for this, say that you are paying out every time.
Yep.
Also need to have UPTs on those.
Yep, UPTs and creatinines.
Yep. I think those were our big ones that we talked about for steroids, right?
Yeah, I think the one we did touch on was kind of the geriatric population. Just make sure that you know that there are neuropsychiatric side effects, and we've had many that got admitted to the hospital because somebody gave them steroids because it gives them full-blown psychosis. Yeah. That and people with actual, psychiatric illnesses, bipolar disorder, depression, anxiety, all of those things. Very common.
You need to think about it. These are not benign drugs.
Nope.
Almost everything that we've looked at says a select group population will benefit, but generally we think that the risks generally outweigh the benefits. So good to have shared decision-making conversation.
Absolutely.
Good to have documentation of shared decision-making conversation, discuss risks and benefits. Good to mention that if they are a diabetic or have high blood pressure or a history of psychiatric illness, that you thought about this and talked to them about this before you gave them the steroid.
Yep.
And then let your patients know it's going to make them a little jittery for a couple days, so they're not coming back to the clinic 2 days later saying, "What did you do to me?" I've seen that a few times.
Oh, absolutely.
This is not stuff you guys don't know. We're just sharing with you what we found when we did a big review of the literature. Yeah. The only other important thing I would say is you need to be familiar with what needs a taper and what doesn't. Absolutely. If you're writing steroids that are very high dose, which for me is once you get 50 of prednisone or over, and I say me because that's what I've seen in the literature, or you're getting past 5 to 7 days, need to have a taper.
Have to have a taper.
Please know the half-lives of the steroids that you're giving. Kenalog can have a half-life of about 3 weeks. Celestron and Decadron, about 36 to 56 hours, I think is what I saw around for both of those. Solumetrol is closer to 20 hours. Solumetrol's actual dose is 80. We give 125 because it's what's in the bottle. Toradol, good evidence to show that 30 to 15 is just as much efficacy as 60. There's no reason to be giving anyone 60 of Toradol anymore.
With less side effects.
Yeah, 15 to 30 of Toradol is all you need for the same benefits with less potential bad side effects.
Absolutely.
I think the longer video is better.
The longer video is way better.
Sounds like we're just spouting off random stuff here.
It is.
Watch that one. If you guys have any questions, please reach out to us. If you think what we said is crazy, reach out to us. Learning is a lifelong process for all of us. Yeah. David and I like to hear other opinions other than our own.
Absolutely. We love to see how other people practice.
And we'll see you guys at the Provider Summit.
Thank you.
Even there we went over time.
It was crazy.